Good afternoon, everyone. It's now 3 o'clock p.m. Eastern Time in the United States, and I hope all of you actually enjoyed the first hour. Please send me your comments. I did save it, and I will process it, but please let me hear your comments first. Can you all hear me? I see some questions. Yes, it was great. I appreciate that. Any other comments? Very informative. Good, good. Thank you, thank you, thank you. Okay. Let's shift the gears and enjoy the rest of the material, and some of the material actually you're not going to find it in any textbooks for those who missed the first hour. This is essentially where we stand. Let me go over the what we covered in terms of the map that we addressed first. That's me here, and you have all my contact information in the site. And essentially what we covered so far, we completed ion-gated channels, receptors coupled with ions. We completed receptors coupled with G proteins, cascade 7 members, protein, cyclic MP, cyclic GMP as well. We completed intracellular receptors, so what's left for us is kinase linked receptors, and we also talked about the fact that drugs do function as enzyme inhibitors before we took a break, and transporter channels and SSRI drugs that follow actually fluoxetine, common SSRI that is used as an antidepressant agent. Let's enjoy the rest of the lecture here. When we talk about receptors that function as transmembrane enzymes, we like to talk about tyrosine kinase, we like to talk about growth factor, and we like to talk about the coupled system, we like to talk about cytokines. Okay. And we like to appreciate every one of them. Transmembrane proteins. So as a drug, as a ligand, a drug can bind to tyrosine kinase domain. What's the nature of this domain, tyrosine kinase? It forms a channel across the membrane and tends to dimerize, activate phosphorylation of tissue-specific proteins. So growth factor follows this pattern. You can see that here. Transmembrane channel protein, and in essence you activate certain proteins that can send a signal at the genetic level again and synthesize proteins. So the activation of those certain proteins does not really involve a second messenger. The signaling still takes process at the site where you synthesize proteins. So in essence, when you look at growth factor, when you look at tyrosine kinase, you have a channel here. You have a dimer. In a resting stage, that's what you see in here. You can see that they link it together here. See here, two proteins. They link it together by this. After it binds with insulin, for instance, insulin is considered a drug for diabetes. Insulin is a hormone and a drug. Okay. So you can see actually that facilitates the phosphorylation reaction to take place. So tyrosine kinase stands in this side here. And you see you have a wide variety of slides to come and to enjoy. So the phosphorylation here will deal with tyrosine kinase, will deal actually with activation at the cellular genetic levels, will lead to cellular response. So I like actually to enhance this so you can see it beautifully illustrated to you here. That's tyrosine kinase. That's GF, that's growth factor in the previous slide. So that's the inactive state prior to binding, and that's after insulin binds. Phosphorylation of tyrosine kinase that takes place here. Look at this beautiful illustration here. EGFR, epidermal growth factor receptor. What happened here that you have a composite action of those two, growth factor and tyrosine kinase. And I like to show this very nicely to you here. I actually spent until 2:30 last night to prepare for you this decent information so you can see what I'm talking about here. You see the beauty of it? EGFR, epidermal growth factor receptor, coupled with tyrosine kinase. It's the same principle. Phosphorylation reactions at the genetic level will activate series of proteins here. You can see all of those proteins here. Activate gene activations, and that deals with cell cycle progression, differentiation. The problem with that, if you have a mutation that takes place, and you can see actually that we're talking about the same language in terms of molecular signaling, if you are dealing with hormonal action or a drug action. There is no difference. But you have to understand the system. You have to love it. So with certain prostate cancer, breast cancer, you're dealing with overproduction. No control on phosphorylation of those proteins lead to abundant of cells that are produced. So this is the story. If you have a tyrosine kinase, insulin can act as a drug. It can act as a drug, and that's what you deal with in terms of treatment of diabetes type 1. But if you have a complex system like this where you have two receptors are involved and you have abnormal activities going on in terms of growth, so you do need to synthesize additional drug to interfere with this mechanism. How does that happen? This enjoys this beauty of the material here. How does that happen? Is it worth of our time? Is the chess game approach is valid to see the big picture? See the beauty of it here? I addressed it actually in this fashion. See EGFR protein linked by tyrosine kinase enzyme, linked by STAT. What's STAT referring to? STAT referring to inducer proteins. STAT referring to signal transducers and activators of transcription. That's STAT. Various proteins, they have all to be phosphorylated and to get you cell growth, cell survival, and cell proliferation. A mutation that takes place at the site will lead to overproduction of those cells. Over the past 5 to 6 years, there are two groups actually highly active in this research. One is at University of Pennsylvania, where my son is doing his residency now. And I love actually to go and acknowledge those people who did it at the Cancer Institute, and the other Johns Hopkins University Medical School Cancer Center, where my daughter spends the summer in her second year doing research in cancer. So those two drugs here, gefitinib and erlotinib, they will tend to interfere with this process. They will tend to bind at those receptors, but will interfere with the phosphorylation reactions. So let's enjoy that. This is what we're talking about here. Epidermal growth factor, platelet, DG factors, all of those factors can be involved here. Coupled system, you have receptor for tyrosine kinase. You can activate all of those proteins. You can, at the genetic level, synthesize proteins. Abundant of them due to mutation that can take place. Function of those drugs actually is to prevent phosphorylation of those intermediate to take place. Phosphorylation of the key receptor of tyrosine kinase to take place, phosphorylation of RAF to take place in the cytoplasm. So you deal with it just like anti-HIV drugs. When you couple it with protease inhibitor, you're dealing with this as a strategy to control the synthesis. This is the beauty of it. This is what we're talking about. So how EGFR tyrosine kinase inhibitor function? It binds, follows the same pattern. Once it binds to EGFR receptor, so you expect dimerization to take place, you expect conformational change to take place, but as a result of that, that's what you see in here. That's the inhibitor. So it binds to the receptor, prevent phosphorylation of tyrosine kinase to take place. This is the beauty of it. The tyrosine kinase inhibitor, erlotinib and gefitinib. So by this mechanism, you can actually inhibit the metastasis, inhibition of apoptosis, invasion, proliferation. You can knock it off. And at this site as well. So those are common drugs. And you can see the beauty of it in this proposed mechanism of EGFR targeted tyrosine kinase inhibitors. Look at this. Look at this beauty. Look at this. Good job here. And it will happen. I'm writing a text on molecular endocrinology. I like actually to address pharmacology. I like to put all of this information. I like to love it. I like to spend my life in it so I can pass it on to you, pass it on to the new breed of physician scientists to enjoy this material. So you can see what we're talking about here. Phosphorylation reaction takes place. Activation of all of those proteins takes place by STAT, signal transducer and activator of transcription molecules. When you have tyrosine kinase inhibitors, phosphorylation will stop, no signaling, and GI arrest. Let's see what I have for you guys here. I love it. This is what we're talking about, TKI, tyrosine kinase inhibitors. Nuclear signaling prevented. That's the STAT proteins. See here, beautiful illustration again. Inhibition of metastasis, anti-angiogenesis, prevention of tumor cells, survival, and decreases chemotherapy, reduce therapy resistance. So we're talking about the same language here. We're not talking about anything else. What they found actually, the mutant EGFR mutant tumors here, when they are treated by tyrosine kinase inhibitors, so you expect to see a tremendous improvement. You knock this off. Unfortunately, when those acquired a resistance, you can see this will slightly go back, but with chemotherapy and tyrosine kinase inhibition, you expect to see a tremendous progress. And this type of research is still continuing on. This is only started over the past few years, actually. And I do not see it in recent pharmacology texts. So enjoy it. Please enjoy it with me. You can see here what we're talking about actually in terms of amplification, in terms of resistance, kinesis, and you can see the function of TKI, tyrosine kinase inhibitors. And I think I made myself clear about this beautiful piece of work that can actually be added nicely in this section. Last but not least, you already have that receptors of cytokines. We already addressed this, so you're talking about a complex, a coupled protein, tyrosine kinases, along with other hormones like GF, steroid hormones, for instance, and function to activate transducers, activators to modify genes. With that, we very much completed what we like to say about molecular signaling. Let's move on and address how that tie with information that I like to prepare you for it in terms of adrenergic drugs, in terms of cholinergic drugs, in terms of GS, GI, phospholipase, ion channels, tyrosine kinase, and cytokines. So beta-adrenergic receptors, they tie with stimulation of GS proteins, activation of adenylyl cyclase to release cyclic AMP. Alpha adrenergic receptors, on the other hand, does the opposite. Stimulate GI type of G proteins. When they do that, what they're going to do? Decrease cyclic AMP, inhibit adenylyl cyclase, decrease cyclic AMP. And we covered that. What are common adrenergic receptors? So I'm preparing you actually for adrenergic drugs, agonist, antagonist side effects. All the story for the next few lectures. When we talk about adrenergic receptors, we're talking about norepinephrine as a common catecholamine to neurotransmitter. Next lecture, I will introduce you to the PNS and CNS, sympathetic branch of the autonomic nervous system. But here, get used to this terminology before you move on. So those receptors for adrenaline are good examples and among the first GPCR proteins. What are they? What are those classes? So that's in terms of adrenergic receptors, and you have to keep in mind that from now on you're going to look at NM, NN, distribution of those in different tissues. What do we mean really by having an agonist, activate that, versus antagonist? What's the relationship between what's going on in parasympathetic nervous system and sympathetic nervous system, and why? How you deal with high level of agonist, how you antagonize it, and why, what are the substrate What are the receptor specificities involved? Words about muscarinic receptors, and you're going to hear that when we talk about many systems in the near future. So they are sensitive to muscarine. Muscarine is poisonous mushroom, and from there they developed this type, and they actually sorted out the various subtypes. You have 5 muscarinic receptors. Distribution of those varies in different tissues. Some of them are coupled to GQ proteins, so when they couple to GQ proteins, you expect to see they coupled with activation of phospholipase C. You expect to see protein kinase C involved here. Those are M1, M3, and M5 versus are coupled with GI proteins, G2 and G4, M2 and M4. So you expect to see inhibition of adenylyl cyclase enzyme. We already talked about Prozac and SSRI. We already talked about its use as a common SSRI antidepressant agent that will tend to interact and inhibit serotonin transporter. Cocaine function as essentially bind to several neurotransmitter transporter as well. And you have to keep in mind that all of those neurotransmitters, epinephrine, dopamine, serotonin, acetylcholine, biogenic amines, have a specific transporters. So I think we covered that previously. Well, let's enjoy the summary here. That's what I like to end up my lecture with, to prepare you for classes, to prepare you for cholinergic drugs, to prepare you for adrenergic drugs. So we're going to see those receptors. We're going to see the specificity. We're going to see what is happening if you overdose an agonist. How are you going to deal with that? Give a patient an antagonist. Selectivity of the receptors, and very enjoyable. So it may sound a little bit critical in the beginning, but if you're really interested in it, you love it. 2 systems are considered the most difficult systems, actually, for students, medical students. PNS, cardiovascular system. Why is that? Because there is no memorization involved. You have to rationalize things. You have to put the pieces together. You have to go back to this chess game approach and try to understand the function of each piece. Specificity of receptors, how they vary. Prediction on the mode of action of enzyme. Prediction on what happens if you overdose a patient with a specific drug and how you're going to deal with it. So in summary here, I covered here the classes of receptors, muscarinic receptor M1, M3, alpha 1. All of those deal with GQ. Once you hear GQ, you're dealing with phospholipase C. What does phospholipase C do? Act on membrane lipids to hydrolyze phosphatidylinositol to IP2 and DAG, IP3 here, and DAG IP3 acts as a second messenger to release calcium from sacroplasmic reticulum, activate protein kinase C. When you're dealing with beta receptors and dopamine receptors, you are dealing with GS proteins, so you're dealing with activation of adenylyl cyclase to release cyclic AMP from ATP, and as a cascade, you expect to see an increase in calcium influx and enzyme activity. When you deal with alpha 2 receptors and M2 receptors, you're dealing with GI, coupling proteins, inhibition of adenylyl cyclase, decreasing the level of cyclic AMP, decreasing calcium influx and adenylyl cyclase activity, increasing potassium. And with that, I completed this section. So you are ready to proceed on. I listed to you here some of the references that I used, and I hope you did enjoy this lecture. Let me welcome, we still have some time, so let me welcome some of the questions here. And please send me your comments. It's your enthusiasm that will drive me to present and to spend time in making those lectures very fruitful to you. I enjoy it, and I like you to enjoy it as well with me. So let's work as a team to achieve this objective. Let me see here what questions do I have. Okay.
I'm interested.
Yeah, please, when you, I like you when you send me your comments. You have my email. Tell me where you are now and this time is suitable or not. Let me have just one comment. Next week, I may have the lecture at a little bit earlier time because I, unfortunately, I have to travel to the airport, and 2 to 4 will prevent me to do that. But I will have it next week, but at different time, and I will let you know. Thank you. And please send me your comments. Okay. And let me know how can I assist you further. I love you all, and I appreciate having you. And please feel free to invite your professors, your colleagues, and we'll have a great activities between global health education, global medical education, and I will see how can I assist you by all means. Thank you, and I look forward to hearing from you again. Bye-bye.